Yeah, so what we're going to talk about today is very important, and it's something that we've been working on for a couple of years, and I know a lot of you have heard talk of this, and what we're trying to do is clarify what we're doing and hopefully answer a lot of maybe scary questions that have come up to your mind. But just as a start, I'm a board-certified general surgeon, and I'm also a diplomate of the American Board of Venous and Lymphatic Medicine, and here are my disclosures.
Again, my background too, board certified family practice, also a diplomate for the American Board of Venous and Lymphatic Medicine. It's a big deal, you know, seeing this as a collaborative approach from both the surgical and non-surgical aspects and coming together for us is pretty huge.
Yeah. All right, so why are we doing this? This is currently the state of our venous and lymphatic medicine patient. I've heard a lot of you talking about getting referrals from primary care providers and how you hear people saying, we don't know where to send these patients. Well, that's our fault. And part of it is there are so many different specialties that approach this from a unique aspect. But unfortunately, the patient ends up being the one suffering. They get a limited view or a limited treatment and not really the entire complete treatment. So our patients are confused, our referring providers are confused, and it's our job to straighten that out. Now, I don't know if Erin Murphy's in the room, but this is something that we all already know, and Erin published this article in July 2022 of Endovascular Today, also addressing this issue, and I encourage you all to go there to read that. So the problem is we have over 250 million patients with venous and lymphatic disease, and if you total the top three providers being vascular surgery, interventional radiology, and interventional cardiology, that comes to about 11,000 providers for over 250 million patients. And then you take what's happened since COVID, and in a 2021 Mayo Clinic post-COVID study, they found that 1 in 3 physicians, APPs, and nurses intend to reduce their work hours, and 1 in 5 physicians intends to retire and leave medical practice altogether. So that number is going to drop, and we're facing an impending physician shortage for an already serious disproportionate provider-to-patient ratio. Now, take one of the top specialties, vascular surgery, and there was a study that Coleman published in 2021, and it came out, the Society of Vascular Surgery found that their specialty was particularly vulnerable to physician burnout, with the second highest rate of burnout in all the surgical specialties, leading to depression and high turnover and also early retirement. Now, how does this affect industry? Looking at the physicians that we have today that are treating and all the variety of specialties that they come from, they're all getting different training, and the training is not necessarily complete. And what that can also lead to, as well as a confused patient, are unnecessary complications, which then have a secondary effect on our industry. So you might recall the Vici stent being recalled due to migration implantation. So there were 17 complaints reported to those injuries, and that stent ended up getting recalled. So you may have a valid and viable option for a patient that they get taken away from them due to possibly improper training. So it has an effect on the patient, it has an effect on the industry, but it also has an effect on you as physicians. And you heard the talk before this on Medicare reimbursement, how we're struggling with the declining reimbursements. And venous and lymphatic medicine just really doesn't have a complete voice at the table right now. We do not have a designated specialty that we can define ourselves as being different, so we're currently being lumped into vascular surgery, which is not necessarily reflective of what we do for the patients. And it also has an effect on the patient outcomes and many patients being lost to follow-up. So why did our group come together? We came together to define the specialty through the American Board of Medical Specialties, standardize the education and training to be inclusive of all of those different specialties that currently practice, We want to grow the ACGME accredited fellowships. Currently, we have an AVLM fellowship. We want to convert that into an actual ACGME training. Widen the access to care. I think one of the fears many people hear out there is you want to exclude me, you want to make it so that I can't practice. It's exactly the opposite. We want to widen the access to care, but it has to be quality and comprehensive care. We also want to improve the patient outcomes. We don't want patients getting partial care and then ending up no better off when they started. We want to advocate and inform third-party payers that we are a distinct specialty that should be looked at and reimbursed distinctively, and have a voice at CMS. And we want a reasonable timeline. So I know when I started in 2012, I heard about this back in 2012, and it just never seemed to go anywhere. But we really have picked up momentum, and our reasonable timeline is within 5 years.
Looking back at this, the initial effort started as a task force within AVLS, and then as time went on, it became very clear we needed to have this interdisciplinary approach with multiple specialties represented. So on this slide, you can see this is the current structure for the VLM subspecialty work group. Overall, we have it broken down into the writing group, which is actually actively working on updating the core contents document. For some that recall, that was published back in 2014 and was well overdue for an update. And then we also have a subspecialty advisor council. This next slide, obviously you recognize these two folks up here, and thank you for everyone's patience and support and questions as we're taking this hopefully to the next steps for this process. Looking at the breakdown, you'll see some familiar faces on this, and again, you know, from both Dr. Meisner, Dr. Gasparis, Dr. Kalnani, Dr. Marston, Dr. Winokur, Dr. Desai, Dr. Carr, Dr. Carty, Dr. Fish, and Dr. Wasan. When you break down their specialties, we see dermatology, interventional cardiology, vascular medicine, IR, and then our relationship with the AVF. We're trying to build bridges with both AVF and SAR to make this all happen. This is a group process, folks, and by having all these voices involved, that's how we're going to make this occur. I want to also especially thank our administrative support with this. You know, everyone knows Dean, thank goodness, helping provide some structure with this, but we're also coordinating with Keith Hume, Chris Freed, John Forbes, and then Dr. Kirshner from the American Academy of Dermatology has actually been a vital part in bringing through the voice of the dermatologist to this effort. And then Dr. Ralph from Sky as well. Zoe's mentioned some of the interactions we've already had with Tom Granatier, who's provided some great advice on, you know, potential options for making this go forward. But Dr. Radabau and Dr. Ogrink, those are ones that we're continuing to look for to help build structure to how not only the core content documents are going to reflect, but ultimately how this training pathway is going to be developed. And lastly, just a couple things, Dr. Scheer and Brent Wagner and John Kaufman, all three folks that we're listening to as well to make this happen. Great list of this multi-specialty groups, but in particular, and I know you guys are thinking, why is he mentioning all these names? Well, first of all, when you're thinking about this being a multidisciplinary situation, we're learning just as much. Let's say Dr. Robert Adirond, I'm going to call his name out in particular. He's actually from Yale, overseeing the interventional cardiology program there, along with the vascular medicine program. This is an aggressive timetable to make these fellowships occur, and we're already learning that, hey, if we can utilize some of these existing relationships and infrastructure, we may be able to expand these training fellowship opportunities in a faster timeline. Another person I want to call out here who's in the audience here is Tim Strait. Tim is a fellow that I met him a few years back. He's actually a retired Army medical officer who is also board certified not only in dermatology, but infectious disease. and he attends these meetings on a regular basis. The reason why I mention him in particular is we have so much talent in this organization that just by getting to know people, networking, it's amazing how much help he's provided to our group in insight with this. And you know, when you look at this journey that we're trying to pull together, we recognize everyone brings a diversity of backgrounds, and we're hoping to just continue to leverage that as we go forward. There we go.
Yep. So we'll go into, your questions are probably, well, what are we going to do? How are you going to define the specialty? And it's a work in progress, and I'm not going to give you a definitive answer to that today. I know that the questions you'll come up with are all the questions that this group that Jeff has just outlined is dealing with on a daily to monthly basis. And it is ever evolving based on the roadblocks and the complications that we see. But with the advice of Lynn Kirk, she is the Chief Accreditation Officer to ACGME. You might have heard about Society of Vascular Medicine submitting an application for their wonderful program to ACGME, and it was turned down primarily because ACGME looks for the program to first be specialized, to be certified by the ABMS. So although it's not unheard of for ACGME to accredit a program first, there have been a couple exceptions to that. She said really the way to go is get ABMS certification, then apply for ACGME accreditation. Now, you might have all heard the FPD. I think that is probably the most common thing that has been going out and around, and different societies possibly approaching it through an FPD. Mark and I have had Zoom calls with Joe Beiske, the president and CEO of the American Board of Surgery, multiple times. And in our conversations with her, she has expressed the fact that the American Board of Surgery will not proceed with any additional focused practice designation, either from the Vascular Surgery Board or any other surgical board. They have one and found that it tends to be too labor intensive. These are volunteers, too costly, and minimal benefit. So she has had that talk with us, and she's also been supportive in wanting to watch the way the Venous and Lymphatic Medicine work group goes. But definitely the Board of Surgery is not going to get directly involved until there's something to get involved with. I did want to clear up the misconception or misunderstandings, because I felt even after Mark and I had these calls with Joe and relayed the information, there was still misinformation getting out. So I did ask Joe if she would just write me an email, just give me something definitive in writing. And as you can see, that was September 21st, and she did say ABS will not sponsor or co-sponsor an FPD in venous and lymphatic surgery. So that was her definitive answer, which helps in the fact that we can now move forward with some of the other options. And what are those options? We also had a meeting with Richard Hawkins, the president and CEO of the American Board of Medical Specialties. He is very interested in helping us, and part of the reason is their current process for defining a specialty is the same process that began in 1933, and it hasn't changed, and that's a problem. And it is a very bulky process. It's a process that involves the ABMS as well as the ACGME. However, ACGME cannot communicate with ABMS. There's a legal situation there. They can't communicate. They have to communicate with the AMA. There is a liaison committee. The application is reviewed, returned. It is a very lengthy process. So they are actually changing that whole process as we speak. There is currently an application for a new board into the ABMS, and they said it was unfortunate that application was submitted prior to them getting this revamp in place, so that application will hopefully be the last through this bulky process. But they did encourage us to hold off on our application until they've got this new process in place. Now, as far as the process, they are also looking at the fact that there is transition of physicians from one specialty to another throughout their career. They recognize this as a need, not an issue. And because of that, they want to understand what we are doing with our work group, what we are doing at AVLS and the American Board of Venous and Lymphatic Medicine, because we have such a diverse specialty participation. So they are using us somewhat as an example case to see how we navigate this, and are there to help us in any way with their staff to give us background on how they've done it in the past, but also to learn from us to how to move forward.
When you're looking, and I mentioned that about the core content document updates, there are 2 papers that are being updated actively by the group right now. And eventually we will get to the program requirements document to kind of hammer out, okay, what are the procedural numbers and all that. But we're really pushing to make the core content document get into manuscript, finalized manuscript form within at least the next month. That is also going to be helpful to get additional societal approvals and making sure we're checking off the boxes from that standpoint. For some that have been coordinating with the UIP has had a draft document of their core content that we've been graciously presented with, and we're utilizing aspects just to make sure there's symmetry with what we're presenting. And again, we have the societies listed that we're going to make sure we're going to be circling back with. You know, looking at this AVF, SAR, SCI, AAD, Society of Vascular Medicine, all of these, it's great to be able to have this interdisciplinary relationship with. And the co-publication within JVS as well as Journal of Interventional Radiology are going to be goals for this as well.
I missed the V, should be JVIR.
Oh, JVIR, sorry, that's all good. This was a question that also came up in one of the prior meetings, and how will this training look like, and being respectful of folks with varied backgrounds. Certainly a multi-tiered approach is definitely one of the high points of this. But we're going to really do some additional digging on that after we get the core content document finalized.
I'm going to just clarify on the tiered approach. And again, this is ongoing and we are discussing it, but when we talk about tiered approach, we talk about a tiered entry point, but a single exit point. So everything we're discussing here is not going to affect the physicians that are currently practicing. Our goal is to shape the future of the physicians that want to go into this as a specialty going forward. I know that's a big fear for people. What is this going to do? What does this mean for me? Is it going to make it so I can't practice? That is not our goal. That is not the goal of this group. We are very heavily discussing grandfathering. When vascular surgery developed out of general surgery, there was definitely a grandfather situation where those general surgeons that were already practicing could continue practicing. So I really want to alleviate those fears and bristles when that happens. But when it comes to the final product of the VLM physician in the future, they should all have the same education and training. They should all come out with the same technical skills. And again, I threw this out as just an arbitrary thing. Say you have a medical student comes out, wants to be a VLM physician. You say they need 4 years of training to be able to do the entire scope of practice, including deep pelvic and everything head to toe. But then you have a practicing interventional radiologist that has a lot of that training. They would enter a transitional fellowship to go into that with many of the criteria already met, but the expectation that all of the didactic, all of the basic knowledge would have to be updated, and any technical skills that weren't included on the initial training would be included in the fellowship training. And so the exit point of the fellow would look exactly the same as the exit point of the medical student that came out and wanted to train. So that's the tiered approach, not a tier entry and a tier exit.
And that, I think that's also a great point that Mark had brought up earlier, is all these efforts are designed, no current physician will be left behind.
Right.
It's, it's respectful of, hey, we understand the varied backgrounds, but we've got to be thinking about the future for this.
Right. And there are some publications that have come out or will be coming out. My publication, The United State of Venous and Lymphatic Medicine, Uniting the Specialties to Form a More Perfect Union, was accepted by JVS-VLD. And I was told they have targeted November for the publication, so please look out for that. It gives you a little bit more of the history and, why we're doing what we're doing and how we're working together as a unit. Also, Robert Adoran and Jeff Carr teamed together and are publishing or have published a VLM workgroup update in the Sky Journal. And we are trying to work towards publishing in the other specialty journals too, JVIR, just having our members of the writing group and the leadership group take charge of that so we can keep all society members updated, not just AVLS.
In some of the upcoming talks over this weekend, we're going to be revisiting the, what are the goals of Great Expectations. And again, this is an aggressive timeline over the next 5 years that we're going to be expanding the footprint and be looking for this ABMS subspecialty certification. It's time to go after it, and absolutely we are looking for the support and enthusiasm for this initiative. It's a long time in process, and we're building these efforts on the shoulders of giants, but it's time.
And Great Expectations, if anybody doesn't know, I want you to find John Mangold. I don't know if he's in the room or he's out in the hallway, but Great Expectations is what the AVLS, their plan for the next 5 years. And the top of that plan is the development of this specialty and the fellowships. So if you're in this room and any of this is sounding exciting to you and you want to help, you absolutely can help. You can find John Mangold and say, I want to support the Great Expectations platform. And we would appreciate it. What we do, we're all doing as volunteers. We are all giving our time, blood, sweat, and tears. But we do need staff to help. So if you can support us with Great Expectations, we would be very, very grateful. And yeah, so what our goal is also over the next 5 years is to increase. We currently have approximately 7 ABVLM fellowships in the country. We want to increase that to 15 to 25 over the next 5 years. Definitely as we evolve the training programs, those programs may look different. We want to reclaim the oversight of the VLM fellowship from the ABVLM. ABVLM will remain the certification body as it should, and it should be separate from AVLS as the training, but AVLS will take over the fellowship programs with recruiters and a committee that we have here to oversee those fellowships.
And Zoe, a quick one on that slide too. That has been finalized this week. So, when you look at the oversight and the growth steps, that's already occurring. But it's our hope, again, if for those that have academic relationships and such in their communities and that, please let us know. I mean, these fellowships, they're just not going to pop out of the sky. If you do have some existing networked relationships with these academic institutions that you think might be a possibility, we'd be glad to hear about it.
So again, we did discuss some of this, the resistance, the roadblocks. I think the biggest resistance will be what's going to happen to me in my practice. So if you hear and you're understanding what we're saying about this is how we will work to go forward, but we're not going to work to remove or stop anybody who's currently practicing, it would be helpful to us if you could quell any fears in that regard when you hear people talking about this as our publications come out. We are doing this for the benefit of the 250 million patients, not to be territorial about our specialty.
One of the other suggestions, ideas had come out of the National Board of Physicians and Surgeons and such. That was mentioned as a potential pathway for specialty recognition, and I have to do a deeper dive on that for folks that aren't aware. That organization actually follows the same taxonomy in description of specialties that ABMS does. it's not like we can actually go and just approach them and say, well, we want to start a VLM, subspecialty. That's not the way this works. And in terms of the time investment and what we're looking at, yes, we're going to have to utilize the traditional pathways through ABMS and eventually, revisit this with ACGME. And I definitely appreciate the ideas and suggestions for it, but that's not going to be a fruitful option for us. And I did include the link up there. If you want, you can check out their current taxonomy and that. And great, it's great that they have that laid out, but that's not an option for this.
And we're just going to wrap up now.
Oh yeah. Who are the Ted Lasso fans out here? You guys saw it, and certainly from the online lecture, we got to believe with it.
Yeah.
We all come from, diverse backgrounds. We've got to be able to just put this all together, but it's gonna take us coming a long way in order to make this happen.
Yeah, and I predict at our future conferences, you're going to see little ribbons on our tags saying, I believe. I think that was a great suggestion, and then people are going to come up and say, what do you believe?
I can't grow a mustache like you.
No, but yeah, mine is just keep swimming.
There you go.
And just keep swimming. And he always tells me, hey, this is like herding cats, and my answer is, yes, it is, but at the end, it's a big, beautiful cat that we put together, and it's worth it.
Yes,
so thank you. Any questions?
Oh, here we go.
Is this problem unique to the United States? Like, how do our European counterparts handle treatment of this? And is this just primarily because of being credentialed and having access for payment versus some of the other places?
Great question. Yeah.
And are we behind or ahead of where they're at?
Exactly on target. And the UIP document that hasn't been published, but we have seen the entire document, is to address that situation. So the International Union of Phlebology has created a core curriculum that is very thorough and very complete, and it is to address this situation on how should the VLM physician look. And we did look at that document, compared it to our current core document. Their document is a little bit like a program requirement and a core document put together, where ours will come out in two separate documents, but it is happening at exactly the same time. And their hope is by creating this international document, it will encourage individual countries to then define the specialty and follow the same guidelines. It just was a coincidence that we were both doing this at the same time.
I think arguably too, in Europe, especially some of the countries refer to it as angiology, and in that they've had the framework for this for a long time. But I think to actually see an international collaboration like this right now is really unique.
It's timely, yes.
Yeah, I'd just like to suggest that the board reach out to the other organizations that are doing similar things. I can't help but think of the American Academy of Cosmetic Surgery and the deals they've been doing with the American Board of Surgery Specialties, as well as the California Academy of Cosmetic Surgery has been going to an awful lot of trouble doing exactly the same footwork you guys are doing.
So we in discussions with the ABMS and what their advice is, I think the best advice I just got from Tom Granatier last week in a phone call, and he said, don't think about what is there as a certification path. Think about what you want the specialty, the physician, and the patient care to look like. Then mold that to the path and not the path to your specialty. And you are right, and there's also wound care. I think anybody in here that does wound care, but that is part of why they're looking at how we figure this out, because there are other multidisciplinary specialties. I can't think offhand other than wound care, bariatric medicine. There are many more of these specialties, and they do recognize the need to come up with a pathway. But we're trying not to look at where it has not worked. We're trying to work on how this should work with the only focus on the patients that need the care that aren't getting the care. How do we get them to have the care, but quality care with good outcomes, good training, good doctors? And those are the, the blinders that we're using to focus on how to do this. And then continually, these ABMS people that we have here are on our meetings every month, listening to what we're saying and watching. And so are the boards, the vascular surgery board and the radiology board. So they're part of that discussion. But yes, I understand, and that's why we're doing this, because there are other specialties that have had this issue.
I'm actually going to do a deeper dive on that for the cosmetic surgeon pathway too. I'm curious, but again, with what we're trying to ultimately come back to is revisiting this whole multidisciplinary focus, and hopefully we can make that happen in a shorter time frame than we initially thought.
Yeah, I'm going to put the time frame up there. The one and only conjoint board in the American Board of Medical Specialties was a 35-year process, and it was all of this disjointed communication. The moment that the group came together, it was called the O'Hare meetings. They came together at O'Hare because one doctor decided to get all these different people together to create this and just sit down and have meetings. It took 18 months from that moment. So it was 30 years of turf wars and infighting, 35 years, but 1 year to create the conjoint board. So when you get everybody on the same page, things can move quickly and efficiently with great results. It's just getting everybody on the same page to understand the same message and why we need it.
Any other questions?
Okay?
Thanks to
you.
everyone for their support. Appreciate it.